pleasure of introducing is Dr. Lesego Mawela. He's the Scientific Director at Clinical Care Platform. He's a technical advisor for HIV and the TB programs. He's an HIV clinician, and he has more than 20 years' experience in implementing public health interventions. We really look forward to hearing what Dr. Mawela has to tell us today with his extensive knowledge and expertise, also the passion that he has around training, clinical mentorship, quality improvement. Knowing that we're coming from such a diverse country, Dr. Mawela, it's an honor to have you talk to us today, and thank you so much for being here.
Forward, backwards.
Forward and back,
Yeah.
and this thing is the...
For the pointer. Okay, thank you. Oh, thank you so much. Yay, good day. How are you guys doing? The sugar is all high. For the dietitians, for the foodies. I thought you guys are more disciplined than some of us. Yeah, so firstly, just to say thank you so much for the invitation to this awesome event. I want to thank particularly the Nestle group for making this event a success. I've never been in a room with so many food, nutrition, people. I'm quite intimidated. Yeah, but I also want to thank Lindiwe and her team as well for reaching out and inviting me to be here. Is there anyone who knows the clinical care platform? We do a lot of teachings almost every single night, about 15 to 18 live events every single night. So I hope that after this session, some of you would start to join us. So I'm an HIV clinician. I'm not a nutritionist or dietitian. I don't know much about food. I only know the food that I eat, like my yogurt and stuff. And when they gave me the topic, I was like, why are you not just telling me to talk about ARVs and stuff? But I thought it's good, to not be comfortable where you are. You must always do your best in your area of interest, but find those challenging moments so that you keep growing and you do not become comfortable. So we are going to talk about HIV and TB and the issues around, nutrition, the role of nutrition in terms of strengthening the immune system. But because I'm a public health practitioner, I took the topic because in the last, let's say 3-5 years, I've been doing a lot of mortality audits. So people who came to us in the health system for help, and they got TB, and they passed on, So we go there to look at quality, what is it that we did right? Are there few things that we can improve, And in Gauteng, I've probably done this for all the hospitals from Baragwanath to the smallest hospital. And I want to tell you, as our dearest partners and collaborators in this interdisciplinary team, that TB remains a leading cause of death in our country. Most people, yes, people do die from gunshots, which is what generally we get worried about. Vehicle accidents, marikana, whatever you can think of. But I want to tell you that there is nothing in South Africa that kills people more than what TB does, not even HIV itself. So HIV and nutrition are kind of like contributory factors. But TB is a curable disease, right? If you cough, like now I'm coughing a bit, and I collect your sputum, you have TB, and today we even have better diagnostic tests than we used to have previously. One would expect that every person who is diagnosed has a fair chance of surviving TB because we can cure it. Now, in the audits, we see a lot of things, but I want to tell you the one thing, and I've been a very strong advocate of, is that there is no amount of Rifafor, which is the drugs we use to cure TB, that can fill up the tummy when people are hungry. You see, the initial assessment for our patients has a blog there. They say, what is the weight? What is the BMI? Most of the time, for every 10 files, 9 of those files would have that number there. The unfortunate thing is that then it ends up there. Then we move to give refer for, and we hope that, we can save our people by just giving them drugs, So you have a big role to play. I'm going to talk about some of the things here, but I just want you to make sure that you understand that you are very valuable in the health system. And many patients succumb not because they are not on treatment, but because they have other things like undernutrition, which, we do not manage well. Now, when you look at people who have TB, about 58% of them would be classified as undernourished or to be having some form of malnutrition or even underweight. So that's like for every 10 patients, 6 of them would be like that. When you are auditing deaths, it's not 58%, it's almost 100%. It's rare for me to take files of people who have succumbed to TB and find that they had a normal BMI or they had a normal weight. That should then alert you as our collaborators in the care of our patients as part of a team, which we don't appreciate that much, that the work and the knowledge you have is very valuable, and we need to start to look at how can we improve access to this valuable service that you have. So I'll just introduce why then, we talk TB, HIV, but then we start to talk nutrition. Is this important? Is the relationship between all these conditions? What are some of the immune issues which are brought in either by being malnutrition, TB, or even HIV? And can we help our patients? How can we help them? And I think on number 3 there, I'm not the expert. You are the experts. I just did the research and it tells me this is what we need to do. And I'm hoping that you can embrace some of the recommendations and we can start to work together to save our patients. The first thing is that we have a lot of people living with HIV. Globally, they talk about 39 million people living with HIV, but between me and you, we know that 70 to 80% of these patients, they live in the sub-Saharan region. And me and you, we are in South Africa. Therefore, we carry the biggest burden. And even in the sub-Saharan region, South Africa carries the biggest burden. The stats you look at, it's not on the slide, I think at the bottom, tells you about 7.8 million people living with HIV in South Africa. I want to tell you that it's 8.1 million people. So it's a number that is increasing. When it increases, it tells you 2 things. Either we have more people becoming infected, but the bigger part of it is that as a health system, we are doing very well to keep our people alive, right? It's no longer that urgent or an emergency service. Now we are having people who have been on ARVs for 30 years, 35 years, and that's why you have to appreciate what does that bring into the health system, particularly around issues you may be concerned, like your non-communicable diseases. Now, HIV is the most important risk factor for someone to develop TB, but I want you to also be aware that nutrition, have you ever seen an obese person with TB? It can happen, because I know we can be malnourished even when we have big bodies. But on the general scheme of things, it's people who are significantly underweight. And look at the prevalence of malnutrition in people living with HIV is 25%. For every 10 patients you see with HIV, 4 or so of them, 3 to 4 of them, would have malnutrition. And obviously here I should be asking you a question: how many of you on your everyday practice do you see people living with HIV who are malnourished? Can I just see by show of hands? Say, yeah, I do. You see? Yeah, if you look at the hands, some hands are like, I'm not sure, they're like, here, I'm like, there's no follow-up question, so don't worry. you know. But if you look at the numbers you are looking at, almost all of us will be saying, yes, a day cannot start and it ends, and you have not seen a person who has TB, which is a leading cause of death in South Africa. If you look at the relationship between HIV and TB, it's about 76% co-infection rate. It means if you have 10 people who have TB, about 6 to 7 would have HIV. So even the way you care for your people, it should show, you know. And if you have not raised your hand, for me it means there's an access issue, because we know the problem is there. The question is Dr. Mawela me, and I don't know how many doctors are here, my colleagues, are they referring? You know, because that is where it starts. Are the nurses aware? Do they know how to assess our patients and to determine who should be referred? And when they do refer, is the dietetics nutrition service readily available? Or there's one dietitian for the whole hospital, you know, creating waiting times and implications for our patients. Now, it's a vicious cycle. I can't tell you which one starts first. People who are malnourished at some point do get TB. If you get TB, you are likely to be having HIV. But all these three conditions, if you look at them, they do have a negative impact on the immune system, our immune system. Malnutrition, by now we know, if you are malnourished and you lack certain nutrients, you are unlikely to have a strong immune system, you know. If you look at HIV, as it replicates and it produces these oxidants, our patients end up with what we call a leaky gut. That means things that are not supposed to pass through from the gut into our blood system, they pass through. And that creates a whole lot of problems, from allergies, you know, to just not feeling well, being very tired, anorexia there, you know. TB and HIV, most patients will end up having what we call a wasting syndrome. That means they've lost weight such that they no longer have fat to use as energy. Now these two diseases are finishing who? Their lean body mass, which is their muscles. So they tend to be depleted as well in terms of protein. The other thing which is key, which is very important, is that I remember I had a relative who had TB, and they called me, they say, hey, this is what, I asked them, so before he got sick, how often was he eating? They said 3 times a day, a big meal. I said, okay, now he has TB. How many times is he eating? They said 2 meals per day. I said, I said, no, man, feed the guy, feed him. Feed him 5 times. I actually just gave them, I'm not a dietitian, I just made it practical. Feed him 5 times, if you can, 6 times per day. Do you know the transformation that happened by just giving that simple instruction, just to increase the energy input? Because we know all these conditions, they consume the energy, and the energy requirements per day, per week are very high. So these conditions, if a patient or a person has 3 of them at the same time, it's going to be a very difficult journey for them, you know. So how does nutrition drive recovery? We knew about this in South Africa. We had Dr. Garlic, Dr. Beetroot. I don't know if you guys were there. We knew that there was a relationship. There was always a relationship between nutrition and recovery. It's a question of, sometimes even if the message is right, you need to find good ways and better ways. Sometimes even a good way, but if the timing is not right, you know, you might find that you are on the negative side of things. So nutrition has a huge impact in terms of the ability of our patients to recover. You know, there's a nice article, and you'll see in the current WHO guidelines, they've now embedded a full chapter on nutrition and TB. One of the things which is there is the low evidence around vitamin D and the probability of people being cured quicker if they get vitamin D replacement or supplementation. I must use your language, you know. You know, so we cannot undermine the role of nutrition for our patients. If you look at the main key cells which are being destroyed by HIV, it is our CD4 cells, They don't function well if someone's protein is depleted, if they do not have enough zinc, selenium. I cannot teach you this. I'm sure I could easily ask one of you to just come and tell me about why selenium is so important and why we should be supplementing that, you know. We talk about oxidative stress. As HIV, I spoke about this, as it replicates, it produces this oxygen type of radicals. So it means antioxidants may have a huge impact for our patients. TB, all of you, if I was to do a Montauk's skin test, if I assume that you are working also in the public sector or in hospitals, you probably have TB. It's there in your lung as I speak. It's sleeping, it's lying dormant, it's trapped by which cells? Your macrophages. If those cells are weakened, TB can wake up anytime. It's there, it's just sleeping. You know? I say, oh, I wish there was time. Then I'll do the test and see who has a positive Montauk's test. But your simple B complex type of vitamins do help these cells to remain strong. You know, we spoke about mucosal integrity because HIV destroys that lining in our gut, and our patients then present with a whole lot of problems. Cytokine regulation. Remember, as these substances which our body is not expecting, our immune cells will identify them as foreign. Then they produce these anti-inflammatory chemicals. So our patients, they are in a sort of a state of chronic immune activation, which then leads to many other problems. Aging is one of them. Vasculitis, that's why they may present with strokes, non-communicable diseases because of this persistent immune activation. And from a nutrition point of view, I know you do have products that can modulate those things and keep them under control. Don't starve our patients from omega and those kinds of things. Do you have them? No omega-3? No. No. Now the ARVs are a big problem, isn't it? Yeah, they are very good when you are very sick. As soon as you are stable, they can present a lot of issues. One of the drugs we use is TDF, tenofovir. It's associated with renal impairment. If someone is on that drug and they need protein supplementation, you can create more problems for them. There are drugs that are believed, and I do this because I don't know if I'll have time to explain the science, but there are drugs that are believed to cause obesity. Patients come, they've gained weight. Some patients lose fat, not everywhere, in certain parts of their bodies, like the face, and they come to you, you know. So you need to understand all these dynamics between the drugs we use and how they affect nutrition, etc. For me, the main thing, if I had a way in this world, it was just to make sure that every single patient gets that assessment, that initial assessment, at least by a health worker, but hopefully by a trained dietitian or nutritional person. At least you will refer the person back with some plan, which I can then at least know what I need to do as a clinician. BMI, we know it's something that's available, but we know it's not the best way to assess nutrition. There's also biochemistry, A, B, C, D, E, as you see there. I mean, as a dietitian, you need to know the CD4 count. How high is it? If it is high, your patient is likely to do well. If it is very low, they probably need your attention more than anything. They tend to have very low albumins. They tend to be anemic. And yes, don't start with iron. I was here, Prof. Don't start with iron, stabilize. And also only give it, from our case, give it when there's an obvious deficiency, not necessarily, just to give it. And where it's indicated, let's give it. Just the general appearance of your patient, they may be wasted, they may have swollen legs, they may have lesions in the mouth. That means they're not going to be able to eat, Food, let me talk about the environment, where our people come from. Before they were sick, they didn't have enough food. I can tell you now that they are sick, they don't have enough food. So we must do that assessment to assess food security. And as clinicians, as dietitians, we must know the resources that are available in our communities where we can refer them for food parcels, etc. Yeah, and then on your right-hand side, then it's just the red flags, which I think maybe they are more important for the clinicians, we, the doctors, the nurses, to know, okay, this person has lost weight and they need to see a dietitian or a nutritionist. The MOAC. I mean, we have challenges. We don't even know how to measure these things. And you guys know how to measure these things. So how about we partner? So that we give you the right measurement and you are able to trust what we have done, ne? And then we collaborate in the management of our patients, At the bottom there, this is what the drugs can do. Lipodystrophy, this is abnormal fat distribution, but it doesn't just come with body disfigurement. They have high triglycerides, high cholesterol. At its worst form, they have syndrome X with insulin resistance, central obesity, hypertension. That type of a patient is at a very high risk of cardiovascular disease and complications. And it's caused by our drugs. Some of the drugs we can change and give them better drugs. Yeah, and this is important. Maybe one word, dolutegravir, which is we treat the ARVs with 3 drugs. Tenofovir, lamivudine, DTG, dolutegravir doesn't cause weight gain. Ne? It is not the reason why your patient comes and says, since they gave me this one, I'm gaining weight. You're like, go back. No, they were gaining weight before. And they are in the family, everyone, before they became sick, they were already a big person. You give them drugs, they feel good and they recover. Right, that's the first thing. Number 2 is that obesity is prevalent in our setting, So the best way to address weight gain on ARVs is if we help our patients to adhere to your advice when we refer them. Right. Are we good? So these are some of the requirements that are in the various guidelines. They talk about if you have a person living with HIV and they are asymptomatic, so they are well off. Even when they are asymptomatic, their daily requirement for nutrients, especially for energy, is still required that we need to help them to increase their energy intake, which is very, very, by at least 10%. If they are sick, they are going to need a little bit more. If they have HIV and TB, you can see. That's why our patients don't make it. It's because they are taking drugs for a bug that we know, but they do not have enough energy to keep their bodies going. The body just gets worse off because they are still eating what they ate when they were well and healthy. And for me, I see percentages there. I don't know what it means. I can't calculate it. I'm being honest. I know that they need to increase, but you are the ones who know. That's why I'm emphasizing the working together and the collaboration, participating in the multidisciplinary team, the mortality audits. You need to be there to see what's happening to the patients, and that almost all of them, they could have survived longer or better or even fully recovered if we work together with you. On the right-hand side, it's just on protein. And remember, on protein, I said just make sure that they have a very good kidney function. Imagine me telling you the sources of protein. You'll be like, but they are there at the bottom. Okay, let me rush, because I see generally we are 15 minutes behind. I had 45 minutes, so I'm about to get to 30. Let's see if we can just go for it. So, again, so these are some of the things that are recommended, especially in the WHO guideline and the HIV Clinician Society guidelines, that all our patients, they require some form of supplementation. I know they will take that powder. I don't know what you give them. There's a name. They will take it as if it's daily food. And that's where there's a conflict with you. You're like, no, but this is not your daily pap. It's a supplement. That as soon as a patient tells you that, it means they are food insecure at home. And then we need to start to look at how we can link them to community support groups and stuff to help them to have skills for gardening, but also temporarily to supply them with food parcels. So we know that if a patient does not have adequate vitamin A, it is linked to progression of HIV. We see it especially in children as well. So supplementation is very important. I did talk about vitamin D and that the evidence is low, but there is a very direct link between having good vitamin D and very strong macrophages. But the studies in the WHO report talk about quicker cure rates, people just recovering a little bit better, though it's not a very strong evidence. Vitamin B complex, I mean, sometimes it's all we have. Let's make sure that they do have. And then you have zinc, selenium as antioxidants, very good with our immune recovery. And iron, especially if they can get the right food, not necessarily supplemental, but where supplemental iron is indicated, let's make sure that they do get it. This is just on the drugs. So ARV drugs and TB drugs do have an impact on many things. You can see there, if you give dolutegravir, you have to pay attention to calcium, iron, magnesium. What do? They attach to the drug. The drug is not absorbed. It is taken out with the poop, and your patient will have low drug levels. They fail the ARVs because of that. So as you recommend supplements for the patients, also pay attention to what drugs are they taking and what are the potential drug-nutrient interactions. A drug like efavirenz, right, it gets absorbed easier when someone takes it with a high fat content diet. What does that tell you? If they come to you, they say, I'm dizzy, I have horrible night dreams and stuff, just tell them to take it on an empty stomach, for example. Then they do better. Isoniazid impairs the absorption and metabolism of vitamin B6, so that's why we must replace. A drug like rifampicin is a liver enzyme inducer. So any other supplement which has to be metabolized through the hepatic system, this drug will lower the drug levels of that product. So pay attention to that. By the way, dolutegravir increases drug levels of metformin. So patients who are diabetic on metformin should never take more than 1,000 milligrams in 24 hours of metformin. Otherwise, you get very high drug concentrations with some serious issues. Are we good? Okay. How many slides to go? Oh, they've put all the slides, so I can't count my slides. But I think I almost said 300 slides. I'm like, ooh, it's not possible, right? So this one, I already touched on it. That remember, there was a time where people were dying almost. In my community, we were burying people every week. So it was an emergency response. People were very sick. But now we have this 8.1 million people who are stable and healthy. They've been on ARVs for 20, 30 years. You need to follow the transition of the disease, of the epidemiology of the disease, and see that most people are no longer dying from HIV, right? They are alive. But what does it mean? Number one, it means that their bodies are exposed to drugs the longer, longer than it could have been for 30 years. What are the implications? Some people's bones become brittle. They have pathological fractures. They do have now a higher risk of non-AIDS related malignant breast cancer, prostate cancer, lung cancer. And this is because of that persistent immune activation, and now we see hypertension and diabetes. So now it means you can have someone who's hypertensive, diabetes, who's living with HIV, develops TB because of HIV and diabetes and malnutrition. You see now what's happening. It becomes just a big, big thing. And that is now the current situation, the real situation. Those are the patients we have to master and respond to their needs. So just to summarize, I think when I see this slide, I know I'm at the end. WHO has made 4 recommendations. Number 1, let's make sure every single patient gets a chance to be assessed. Number 2, where it's indicated, let's supplement nutrition and save our patients. Let's have a household-centered response. They are saying for every TB patient you see, there's more people at home who are undernourished. nourished. And you'll find that you can actually help the family. And lastly, let's integrate TB care in your everyday work where you operate. I was going to close with a case just to ask you if you have a 34-year-old lady who comes to you as a dietitian. You can see they are living with HIV, they have TB, the CD4 count is 156, the viral load is high, look at the BMI there, the weight, they are on DTG, they are on TB, What are you thinking? What is your problem list, looking like? It's a typical patient, right? So don't forget the BMI is low, the weight is low, the CD4 count is low, they are on ARVs, they need B6, they are on rifampicin. If you are supplementing vitamin D, it will eat it out. Don't forget to check where they come from and what did they eat the last 7 days, and then help the whole family. So the key take-home message is that number one, malnutrition, HIV, and TB in South Africa is a reality. We have one person who may have these 3 plus 2 more things at any given time. The second take-home message is to help people to have enough energy intake. For me, in the community, that's the first thing I can do as a doctor, because at least I just tell them, increase the number of plates. But the detail as to what must be on the plate is known by you guys there. And then let's supplement, micronutrients as needed. And then number 4, don't forget that the disease has shifted to a group of people who are alive, who are productive, but now they have all these other things, cervical cancer, etc. And do go through the 2025 WHO guidelines. There's a full chapter on nutrition and the different things that you can do. And as the nutritionists, dietitians, you are very valuable. I want to tell you that, don't ever doubt it. We just need to work together, me and you, to see how we can work together for the benefit of our patients. And you'll find the references, the slides will be shared with you. Thank you so much for your time.
I wanted to say thank you very much to Dr. Brazil nuts and fatty fish and maybe a little bit of garlic. But I don't want to make light of such a serious subject, and perhaps I can say thank you again for highlighting the important role played between the clinicians and the dietitians and nutritionists. So we'll open the floor up to questions to Dr. Mawela and also for our online audience.
Awesome. Thanks, Yua. Thank you very much, Doc. Yes, so thank you for opening up the floor, but we can close the floor just for 1 or 2 seconds. There were online questions here. Doc, there was a statement that you made about specific medicines. The one starts with the D, Dolutegravir and metformin.
Yes.
Can you please share the reference or article for the energy and protein requirements for HIV patients that were displayed? So that was a request from the audience.
Okay, so okay.
So I think that was answered.
Is that a question?
Fair enough.
Okay.
Yeah, I don't know. I'm not sure. Was it a question? Was it a statement? Oh, do you mind repeating that statement?
About dolutegravir and metformin. Yeah,
That's right,
okay. Yeah. Okay. Now I'll talk to it. If it's about drugs, if it was selenium, I was going to go back and say, what? Okay, so firstly, when we treat HIV, we treat with 3 drugs: tenofovir, lamivudine, and dolutegravir. Ne? But simply just keep it as TLD and say the D drug has a strong drug-drug interaction with metformin, which we use for management of diabetes, right? And remember now, most of our patients, a good proportion have both, right? What does it do? So dolutegravir slows down the metabolism of metformin. That means our patients will end up with very high drug levels, toxic levels of the drug, right? And we do not want that. They can have very low sugars, they can have lactic acidosis, etc., etc. So the rule is, if a patient already is diabetic and maybe they are being started on ARVs, we need to look at the dosage of metformin. In a 24-hour day, it should not exceed 1,000 milligrams, right? We do, take chances. If someone is taking 2 850s, we do start and see how it goes. But if they are on 3 850s, that is almost 2,000 milligrams or something like that. That is going to be a little bit too much for your patient. So you would rather then consider not using that drug from the ARV side or consider an alternate treatment for diabetes. Yeah. Does it make sense? Okay.
Yeah, certainly, it makes sense to me. Thanks. Don't go anywhere. We're going to open the floor. If there's anybody in the room who'd like to ask Doctor a question, Fulu and I will both head in this direction.
Okay, thank you, Doc. When dolutegravir was introduced, they used to say don't give it to pregnant women, but now it's like it's no longer visible in that regards.
Yeah.
Can you kindly assist what really happened or
Yeah.
what was the...
Yeah.
Yes.
Yeah, it was mainly based on studies done in Botswana, and it was a signal, right? That means there was no official confirmation that dolutegravir was teratogenic, right? And they thought kids would have your neural tube defects. Then the same study, which was done in Botswana, was repeated. The signal was not picked up. And the main thing about Botswana was the lack of fortification with folate and other things, which was sort of set as the reason. But the same studies were then replicated in other countries, including here. In South Africa, we now have we have 8 million people, and the majority are also pregnant women, and we haven't seen a rise or an increase in neural tube defects, and we've been using DTG now for almost 4 to 5 years. So it has been dispelled. Just remember that when you see a pregnant woman, remember there are a few things about her. She may have heartburn, that means she's taking an anti-acid, which may have magnesium or aluminum. She's likely to be on calcium supplements, folate, and maybe iron. All those things may impact on the ability of the body to absorb dolutegravir. That's why we say if they are taking those supplements, one of the best advices you can give the lady is to take DTG 2 hours before the supplement. If they take the supplement first, DTG must be taken 6 hours later to avoid the interaction. Yeah. So that's important.
Hi, me again. Sorry, I didn't introduce myself the last time. My name is Renee Lueli Sufi from Chris Hani, Paraguanath. Less of a question, more of a comment for my colleagues. I think we need to redefine what malnutrition looks like, especially in this population group. Why do I say this? Because of all the things that Doctor has shared with us now, that yes, there's very serious body recomposition that happens when you are HIV positive, right? So if we're going to go by BMI, which a lot of us I know still do, because that's what the guidelines say, I think it's very important that we shift away from it and maybe more towards sensitive measures of malnutrition. So a MWAC for muscle mass, if it's available, we can do bioelectrical impedance, so we can actually see if, yes, BMI is 22, but you have significantly lower lean body mass, you've got a lot more fat, or whatever the case may be. I think it's very important that as far as we possibly can, we need to examine what in truth malnutrition looks like in this population group. Thanks.
Wholeness. I'll just say wholeness. The other thing that I saw is the percentage. We don't use it that much. But if someone's BMI is 18, but they lost 20% in the last 30 days or 60 days, versus someone the BMI is 19, but they've been like that forever, they lost. You understand? It's like if there was a graph, you would see, oh, this one is in trouble, this one is a little bit in trouble. So that's why just to say the BMI is not helpful sometimes. Yeah.
Thank you, Doc. I just wanted to ask the relationship between the leptin hormone with the patients with HIV and TB patients. How do they relate? Thanks, Doc.
Hey, remind me what leptin hormone is used for?
Leptin hormone, it controls the metabolism. It's the one that gives us if you are full, satiety, or hunger.
Yeah. Yeah, I don't know what the relationship is. What I know is the following from our patients. Number one, when they are not well, their appetite drops significantly. That is the most clinical thing we know. The second part that we know about them is that as soon as their immune system recovers, their appetite recovers. So there are two things. We need to help our patients from a nutrition point of view. How can they get enough energy during a period where the appetite is very low? But also when it's time for recovery, because now they come and they are obese, it's like they keep to your original instructions even when maybe the body has recovered and they no longer need certain, replacements or supplements or even the energy supplement that you have prescribed. That is how I would put it. As to whether HIV affects the hormone directly, I do not have evidence for that. I will have to review that, yeah. But practically, let's just assess our patients. And because I jumped the slide, which was talking about your role as dietitians, I think the weakest part for a patient who may get access to your service is the monitoring. It's like, I saw her, she's okay. But now she has recovered, Does she still need to have, let's say, if it was me prescribing 5 plates, does she need 5 plates? No. But she's continuing because that was the last time you saw her. And now she's big and she says it's the drugs. So let's track.
That's a very, very relevant comment you make, Doc. I'm also quite passionate about that. It's like, no, you're big because you eat too much. Doc, so I think just in conclusion, a last question we have from the online audience, if you're able to answer. The question, what they're asking is, are there specific nutritional guidelines for HIV-associated enteropathy?
Yeah, not really, because from an HIV perspective, okay, few things. Enteropathy has 2 things in the HIV world. One is that they may present with malabsorption, so that needs to be assessed and to understand if there are deficiencies that need to be supplemented or replaced. But the same enteropathy may affect the absorption of drugs. So you'll find that a patient has TB, they're on the right treatment, but when you do drug levels and stuff, they are very low. So we need to respond to that. The third thing, which is what I spoke about, is when they have a leaky gut, where you have penetration of toxins and bacteria in the blood. The best treatment is ARVs. The sooner you start them on ARVs, it allows the gut to recover, because the pathogenesis of that is the oxidants released during HIV replication. The last and the most important thing is diarrhea, chronic diarrhea. So in our setting, we have to investigate our patients, ensure that if it's infectious, it is treated. If it is due to the drugs, it is treated. And if those are excluded, hopefully as we treat the HIV, then it responds. In terms of the guidelines, the South African HIV Clinician Society has a full guideline on nutrition and HIV. And there may be additional things to look at it, the issue there may be more information on the issue. Yeah.
Fabulous, fabulous. Thanks so much. Thanks for sharing with us today, Doc. We thoroughly enjoyed you. Yeah.